lot of patients who are diabetic have significant peripheral neuropathy, where they typically cannot feel the bottom of their feet. And of course, that has a lot of implications, not only to the nerves, but also to the muscles and the tendons and the bony structure of their feet. This isn't just in diabetic patients. Usually they're neuropathic for some particular reason, whether it be a medication they're taking, a spinal issue, any sort of nerve damage, even alcoholism, a lack of a nutrient, anything like that can lead to neuropathy.
You do, in fact, treat oral wounds in a similar fashion to what our podiatric surgeons are doing. And it's important that we really understand the value and the worth of what it is that we bring for our patients experiencing systemic disease.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, an Endeavor Business Media production. I'm your host, Andrew Johnston, and thank you so much for spending time with us today. We have a great show for you lined up with Katrina Sanders and her sister, Dr. Elizabeth Sanders. They are fun, they are smart, they're awesome. You're going to love this episode. But beyond today's episode, I'm really excited about the next several things that we're putting out on the podcast feed. So in 2 days, on Friday, we're going to be putting out a show that I actually just finished recording a little bit ago with someone who had 6 screws sunk up into her palate so that they could attach a palatal expander to that spot. And she's an adult. We've been told so many times that this isn't a thing that adults have, but here we do have a real live human being that had it done. And it was so interesting to listen to her journey from childhood, kind of what was wrong with her malocclusion then, and then kind of what happened in the year since, and then why she made that decision to do it now. And another really interesting little bit was that she explained how some other facial features changed other than just her maxillary arch. Okay, then next week, we have an episode that I recorded with some of the new ADHA leadership. We had way too much fun on that episode. And to me, it felt like a group of people, I mean, probably just like our people, like people that you want to hang out with, people that are, you know, they know how to have fun. They definitely know how to work. They're honest, they're passionate. I didn't get that kind of stodgy feeling. I didn't get the feeling or the sense that they're, you know, speaking on their talking points like, you know, kind of like politicians do, right? They don't actually answer a question, but they answer something else that's not even related. They didn't do that. They were honest. They're forthright. They were just a lot of fun. And I think I said this in the episode that if that is what they are like whenever they kind of get around each other, I am surprised by how much work they've already accomplished, because to me, it just seems like it'd be a party every single time. So that's going to come out. And then in a few weeks, we're doing an episode on the tongue, which I don't remember if we've done very many episodes on the tongue. It just doesn't seem like, it seems like the tongue was a part of the conversation, but it wasn't like the focal point of the podcast. So we're going to do an episode on the tongue. And I'm really excited about that one because we're going to bring on a guest who's going to teach us something completely different. Something that you never are going to learn this in hygiene school ever. And it's where Eastern and Western medicine, I guess, either come together or they're at odds. We actually haven't recorded that one yet, so I'm not really sure what the outcome is, but it's fascinating. As soon as I saw it, I'm like, oh my gosh, I need to have her on, because if that's what she's going to talk about, this is going to be crazy. So I'm sure that you're not going to want to miss any of that. Make sure you're hitting that subscribe button on your podcast app. And while you're hitting that subscribe button, if you'll do me a favor, please rate and review the podcast. I know I beg for this all the time, but I think it's really important. We love Apple Podcasts or Spotify reviews, but really any podcast app will be incredibly helpful. So thank you for that in advance. Also remember that this particular episode was a swaparoo episode with one of our fast facts. So it's going to have that same feel, the normal vibe that you get with Fast Facts Perio and Katrina. It's just going to be a little bit longer, and she has a guest on. So you're going to love it. Please enjoy this episode with Katrina Sanders and her sister.
A tale of two hygienists.
Hello, and welcome back to another episode of Fast Facts Perio Edition with your favorite perio-loving ginger, Katrina Sanders. Today, I am so excited because I'm bringing to you your favorite diabetic foot ulcer-loving ginger, Dr. Elizabeth Sanders. Welcome to Fast Facts, Dr. Sanders.
Thank you so much. I'm so excited to be here. Thanks for having me.
Oh my gosh, I'm so excited to have you. I've been talking from last week and now this week about diabetic ulcers and looking at some of the complications that we see with patients. And, I sent you that research study that we talked about last week on Fast Facts. So I'm going to ask y'all right now, if you have not listened to last week's Fast Fact about diabetes and some of the details we're starting to see around adjunctive periodontal therapies in treating diabetes, I'm going to ask you to pause right now, go back to last week and listen to that episode, because that research study absolutely blew my mind. When I sent it to you, I was like, okay, we have to sit down and have a dialogue about this. So I'm so excited to have you on Fast Facts, because today what we're going to be looking at is how you, as a foot and ankle surgeon, look at and address diabetic ulcers. Now, it's important that we understand this. Will you give a short overview as a foot and ankle surgeon about what your relationship is with diabetes?
Yeah, and that's a really great point. In fact, I would say over 60 to 70% of my patients are diabetic. It's very important that patients come to us specifically for routine care just to get their foot checked, because a lot of patients who are diabetic have significant peripheral neuropathy where they typically cannot feel the bottom of their feet. And of course, that has a lot of implications, not only to the nerves, but also to the muscles and the tendons and the bony structure of their feet. So it's important that they come and we take a look at their feet. But a lot of the times patients come to us because they have ulcers on the bottom of their feet. We just talked about how patients have neuropathy, they can't feel very much. So a lot of the times people will walk or something will be in their shoe, they'll maybe step on something and this can create an ulcer. Or because I just talked about the contracture of different muscles and tendons can create different deformities of their feet that can then lead to ulcers. So again, most of the time we'll see patients with significant ulcers and also peripheral vascular disease that can lead to these ulcers.
It's crazy when you talk about this, because, I'm listening to this through the lens of, as an oral healthcare practitioner, how does this impact me, right? When you talk about diabetic neuropathy, which is a real thing, and this is where you oftentimes will see diabetic patients come in. We've talked about this before on other collaborative pieces we've done, that oftentimes patients don't know they're diabetic. They come in, they see you because there's a problem, right? Gosh, there's blood in their sock or whatever. And I will say, all of the oral healthcare practitioners driving to work this morning are like, must be nice that your patients think it's weird that they bleed from the foot. Because of course, in the oral cavity, everyone thinks it's super normal to bleed from the mouth. And we know that that's not necessarily healthy. However, this diabetic neuropathy really blows my mind, because my question, or rather what I'm starting to think about, is if the patient doesn't feel pain in their foot, and so then they experience this trauma or injury that creates an ulcer that sends them in to see you, what is the likeliness that that diabetic neuropathy is also occurring inside of the nerve endings in their oral cavity, right?
Thank you. I've thought about this so
crazy.
much as I talk to you.
It blows my mind. So they may have, and we know periodontal disease, unfortunately, can be a relatively asymptomatic disease. And by asymptomatic, I don't mean, ulcerated bleeding and things like that. What I'm talking about is it may not hurt the patient, or their pain reception or perception may be adjusted. So something to kind of think about with our diabetic patients in the oral healthcare side, right? There's a possibility that whereas this should hurt them a little bit more, that neuropathy piece could theoretically be occurring in the oral cavity, which is like crazy. So
I couldn't agree more. I think that's so interesting.
I love it.
So people they can't chew correctly. If, there's some sort of trauma to their tooth that they can't feel it. And honestly, just losing a tooth is almost nothing to them.
100%, which is amazing, because I have one of my favorite programs. I have this video of a dentist extracting a tooth right next to a video of you amputating somebody's foot. And it, of course, people love seeing this video because they're like, oh my gosh, it's so crazy, and it's interesting to see what a foot amputation looks like. We know what extractions look like. We see them a lot. But the reality is amputating a foot and amputating a tooth, those are body parts. Those are components of the body. And those are ways that the body explains to us that it's in a state of distress. So as many times as you're seeing patients who are coming in with diabetic foot ulcers and maybe don't have a diagnosis, but receive that by receiving your care, right? Hey, this doesn't look right. We should test you and get you a diagnosis of diabetes because that's what this looks like. There's a high possibility that we in the oral healthcare space see patients with diabetes don't have a diagnosis, but we're seeing diabetic oral ulcers, right?
That's so true. And even people with the smallest little foot ulcer can actually be, it's almost like an iceberg, right? There's a huge impact to it that any sort of open wound can easily, very quickly become a terrible source of infection. Think about the mouth. It's probably the same way, yet the mouth is much closer to the brain.
To the brain and the heart muscle. Yes, as we know. So the reason I wanted to chat with you today is because I've gotten my hot little hands on this chronic wound guidelines document. This is a document that you podiatrists use, right? That anybody who treats wounds reviews. And inside of the research studies that I've been looking at around periodontal wounds, there's a lot of data that's really leveraged these chronic wound guidelines. So what I wanted to do was walk through with you the steps of what a podiatrist does when a diabetic ulcer is detected, step by step. And I want to see where those parallels are inside of the oral cavity. So
this sounds wild.
Let's do it. Yeah, I know.
People are not going to think we're going to find parallels, but we will.
We're going to do it, everybody. That's right. Yeah, it's a sister act. We're going to do it. Darn it. I didn't tell everybody, by the way, Dr. Elizabeth Sanders is my sister. So she's my younger sister.
Oh, yeah.
For those of you who don't know. So, okay, let's start at the top, right? Okay. So when addressing a diabetic ulcer, the first step, according to this document, is a diagnosis. So give me a rundown. Diagnosis. What are you looking for?
Yeah. So, I mean, usually a patient will come to us whether they know they're diabetic or not, and they'll have this open sore. And you kind of alluded to this, that, they'll notice bleeding in their sock of some sort. So there has to be a reason behind it. And look, this isn't just in diabetic patients. Usually they're neuropathic for some particular reason, whether it be a medication they're taking, a spinal issue, any sort of nerve damage, even alcoholism, a lack of a nutrient, anything like that can lead to neuropathy, right? So a lot of the times they'll see this open wound. And of course, we have to figure out kind of what's the reason for it. Again, most of it is because they don't have sensation. So we see ulcers on the tips of the toes, underneath the knuckle joints, to the heels. There is a deformity called Charcot foot, where the foot kind of collapses and fractures. And Katrina, you're kind of an expert on that.
Kind of an expert in it. Yeah, I basically am.
Yeah, she loves Charcot feet. You did. Well, one time you were at a conference at one of my conferences and you diagnosed it. Yeah. And no one else had
no one else knew.
You knew.
Yeah. I'm basically a podiatrist. So,
but we also have to address other things like even vascular problems.
So, and I was just going to say, so you're in here, we're looking at, the pulse in the foot, the amount of oxygen that the foot is getting, arterial flow, neuropathies, all of those things. Those are all things that you're looking at in order to surmise a diagnosis.
Yeah.
In dentistry, how do we diagnose a oral ulcer? That is our probing, that is our comprehensive medical survey of our patients, that is salivary diagnostics in many cases to be able to gather some of that data early on. That's gingival indices, that's sulcular bleeding indices. That diagnosis could also be looking at our 3-dimensional radiographs. gathering that diagnosis is absolutely critical. And we know that there are so many assessment pieces that help us to drive to a critical diagnosis. And when we talk about diabetes, we recognize that diabetes can contribute to, when we're talking about perio, because we know there are other oral issues, xerostomia, decay, all of those things. We're talking in the perio realm. We know that diabetes can contribute to gingivitis and stages of periodontitis, as well as advanced grades or progressions of periodontitis. So we know that diabetes is very rooted inside of our diagnosis. So that's step one. Step two is offloading. What's offloading?
Yeah, so in the case of a diabetic foot ulcer, of course, it would be any way to try to mitigate the forces that are contributing to the foot ulcer. Of course, it's difficult, right? Our patients walk on their feet. So it could be anything from a surgical shoe. Sometimes we use like a foam that will kind of cut and offload the area. We might put them in a surgical shoe or a boot, or even give them crutches, or even tell them that they're completely non-weight bearing and put them in like a rolling scooter or a wheelchair.
Mm-hmm. So this is interesting, and I know we co-present quite a bit together, and it always blows my mind that you spend a lot of time focusing on offloading. And quite honestly, in dentistry, we really have not until recently, when we started to recognize that occlusion, bruxism, clenching and grinding, the way teeth meet, whether that's a super erupted tooth, mesial drifting or tipping, that those components or those things can in fact contribute to advanced bone loss or advanced attachment loss. So for us, the offloading could look something like an occlusal adjustment, which we do in perio all the time. That could also look like a bruxism guard for our patients. And then of course, in advanced perio surgery, that could be nothing hard, crunchy, or sticky, nothing with small seeds in it, things that are soft for the first 2 weeks following periodontal surgery, so as to offload. So
is a guard like almost like a mouth guard?
Like a mouth
someone
guard.
wears?
Yep.
Mm.
Okay, let's look at step three. Step three is infection control. So we are looking at debridement and assessment of that infection. So walk me through your initial infection control step here.
Yeah, so if I'm concerned about a diabetic foot ulcer that may be infected, of course, I'll see things like redness, erythema, pus or purulence, malodor. It might be a wound that kind of probes deeply, even sometimes to the bone. Usually if it does probe to the bone, that typically means there's a bone infection. So usually when I'm concerned about an infection, let's say I see this patient in the clinic, I'll take a culture. So I'll cut out a small sample of it. And if there's bone there, great. I'll take a small sample of bone because that's more specific. And then I'll treat them with antibiotics, whether it be a topical antibiotic or an oral antibiotic. Sometimes if it's very severe, I may need to admit them to the hospital to start some intravenous antibiotics. In diabetic foot ulcers, typically the culprit is a more gram-positive type of bacteria. Although if it's very, very concerning, I may want to cover some gram-negatives. A lot of it depends on kind of the source, but again, mostly gram-positives.
This is awesome because what you're doing here is you are looking at that granulated tissue and you're recognizing that because this tissue is already ulcerated, the first thing we need to do is put something topical on it, a topical antimicrobial, because of how friable, fragile, and infected that tissue is. So that's your first step, right? Is the removal of necrotic tissue and utilizing that topical antimicrobial first and foremost to treat that wound, which I absolutely love.
We even say the best antibiotic is the blade because that means getting rid of the infected tissue. How about you?
So, this is an area where dentistry is not as strong or savvy right now. Now, when we take a look at step 4, the wound bed preparation, okay, dentistry is awesome there because that's where we're going to, debride the tooth structure and all that. So stay tuned as we talk about step 4. Step 3, we really aren't doing in dentistry. And in fact, this, I think, is one of those really grand missed opportunities is when we see diabetic patients, you ask any dental hygienist across the United States, what is something we need to think about with diabetic patients? They will respond in unison. They all have delayed wound healing because we know that about a diabetic. But part of that issue is, so what the heck are we doing with that wound? So there are, medicaments, topical antimicrobials that can be used pre-procedurally for a spectrum of time to help treat, or rather place an antimicrobial into that granulated tissue to help address any of that tissue necrosis and at least improve the quality and the resilience of that tissue before we get into step 4, right? So these would be things like periodontal gels or wound cleansing medicaments that are available on the market. Step 4, that's where dentistry, particularly dental hygienists, love to shine. And that is your wound bed preparation. This is where you're doing a cleansing and a debridement, right? This is where now you're really going in. So talk to me about your wound bed preparation in step 4.
Yeah, for us, for wounds, I mean, there's always a delicate balance between inflammatory tissue and good tissue, right? So we're trying to find a good balance between that, kind of managing the pH, kind of managing infection. We talked about that. A lot of the times in diabetic foot ulcers, we love to see that red, beefy, granular is what we call it, tissue. We don't like to see yellow, or obviously we don't like to see infection, but we don't like to see this yellow, what's called fibrotic tissue, because that's too much inflammation. And then a lot of the times as the wound contracts, there's excess skin around it. It's almost like your body trying to repair itself. So our objective would be to kind of debride away any of that excess skin that's preventing the wound from contracting, and also take away that inflammatory tissue, which is a lot of what you do.
It is. And in fact, what did you call the tissue that you like? It's called...
we love granular...
red beefy.
We call it red beefy. We want it to look like a steak.
Red beefy. Okay. So we call it like a juicy tomato. Is what we call it in the perio space.
I like that.
Yeah, it's yummy. And this is again where we're looking at examining the patient as a whole. Yes, we do look at their systemic diseases, their nutrition levels, and this is where we also look at the quality of the tissue. What we aren't focusing on as readily is how oxygenized is that tissue? Is it that bright red tissue, or is it more on the blue purple chronic side where you see that deoxygenated sluggish blood in the area? Those are not things that we're necessarily readily examining. But this is, of course, then, yes, where you would perform that debridement. For us, that is the removal of calculus. And some of us are still removing necrotic cementum. We should not be, but some of us still are. The important piece inside of this step 4 as well is where you are also looking at the reevaluation, the rate of wound healing that occurs, and now being able to observe how the patient's body responded. So I would say the important piece in step 4 that dentistry does not routinely do, but should be considering, is how do we evaluate the success of our treatment? That reevaluation becomes really critical. Step 5 is dressings. So tell me about dressings.
So again, we talked about how the environment of the wound, there's always this delicate balance. And this is why, we can talk about this too. We evaluate our wounds typically every week or every 2 weeks. So we're constantly evaluating it, constantly changing. So if a wound is moist, we want to kind of make it more dry. If it's too dry, we want to keep it a little bit moist. There's always a delicate balance, and we have plenty of wound care products that we can use. So, and again, I see my patients on a weekly or bi-weekly basis. I know you don't have those capabilities, but that's kind of what we're doing with our dressings, and the frequency to which we're telling our patients to change their dressings. That's also a delicate balance.
Yeah. So in dentistry, we have periodontal dressings. They are quite rarely used now, but these, periodontal dressings or packs have been placed over areas to help kind of protect stitches or help protect the tissue graft and things like that. Because we are not using those dressings anymore, we do need to think about the fact that the oral cavity is extremely moist. It is oftentimes quite acidic, and we've genomed, well over 700 unique microorganisms in the oral cavity. So again, when it comes to dressings, this is not something that we are routinely doing. we will oftentimes send our patients out with a product called chlorhexidine, which we've now begun to identify that chlorhexidine actually kills a lot of the beautiful fibroblastic cells, osteoblastic cells that we do in fact need in the body in order to perform that periodontal healing. So as of right now, the gold standard of dressings has really started to evolve. And this is where our wound care opportunities can really, continue to drive into our oral hygiene medicaments. What products are we using that can provide a protective layer, a mucosal barrier protection for our patients? Step 6 is probably similar to what we see in dentistry. Step 6 is surgery. So these are for like more advanced cases, right? Like if they were non-responsive in some of these early steps, then you'd move them into step 6 where they would go through a surgery.
Yeah. So in the case of feet, usually it would be some sort of offloading surgery, like we talked about. So a lot of the times in the foot, there are deforming forces, whether it be bony or ligamentous. The Achilles tendon, for example, has a tremendous impact on the pressure, especially on the forefoot. So sometimes I may take someone for what we call a prophylactic Achilles tendon surgery. You may take someone for even a toe amputation just to offload the area, or cut a tendon that's, flexing way too much. Or we may even take out some bone, for example, the knuckle joint, just to kind of offload that area to help the wound kind of heal.
And so in perio, we do that if we see areas where there's an advanced furcation involvement around the tooth, or let's say there's a root concavity or the bone just needs to be remodeled, our doctors can go in and remodel those areas. That could also, by the way, look like referring our patient to an orthodontist to reposition the teeth so that now they're in a better function to, of course, potentially prevent down the road other future issues. Step 7 is the use of adjuvant agents. Is that correct? Is that how you say it? We call them
I think
adjunct.
so. Okay. Adjuvant.
Yeah, we call them adjunct agents. So these are different types of agents that may be a bit more experimental in nature, but can have enough data to them that we're starting to get a bit more futuristic in that. So what would that look like for you in the podiatric space?
Yeah, it would probably be more, again, things that are kind of outside the norm. So even using things like stem cells or PRP or these special wound care dressings that are probably a little bit more expensive. It may also include hyperbaric oxygen therapy, which, research shows different things. But if a patient has peripheral vascular disease, it may be an option for them. Even considering, we do have things like what's called wound vacs, where it's almost like a sponge and it hooks on like a vacuum. So that to kind of prepare the wound for eventually another type of major surgery, like a skin graft, where we would take a portion of their thigh and then transport it to the foot. Those are things that we may do. And I saw some stuff that you do when I shadowed you in your clinic, doing very similar things, but I'm interested to hear you.
Yeah. So, bone grafting and things like that are, routine layers of what we do. But yes, we do PRP and PRF. So those are adjunctive services that we can in fact use. Lasers we use to help support. Sometimes we're doing like ozone therapy and things like that. So we're starting to see some of those futuristic components coming down that I think are starting to really corroborate and actually integrate themselves as more of a protocol than it being seen as an experimental thing, as we're continuing to see really terrific response. Interestingly enough, we're going to get to step 8 in a second, but interestingly enough, inside of dentistry, again, the pervasive use of antibiotics is not a routine piece that we've seen. And I think that's important to call out, because as we take a look at these are chronic wounds where, your antibiotics might be great for an acute issue. But when we're talking about chronic wound treatment, we recognize that we can't just chronically have our patients on antibiotics long term. So that chronic treatment becomes really important. So
thank you for saying that. And even when you mentioned the thing about chlorhexidine, I think a lot of the times antibiotics are overprescribed. And a lot of the times patients will ask me, I should be on an antibiotic. And I think we're overprescribing them and not helping our patients.
Yeah. And it's so easy when the patient says, I think I should be on an antibiotic. And it's like, because we don't know. We're so, particularly in an industrialized country like the United States, we're so accustomed to, doing these systemic antibiotics all the time. Gosh, that is just not serving us. So step eight is the prevention of recurrence.
Yeah.
Walk me through that.
Yeah. So this is the important part that I talked about, where patients are coming to us for what we call routine diabetic foot care. We hate the word routine, but it is what it is. This is where they're coming to us every few months, and we're checking their feet, we're trimming their toenails, we're making sure they're wearing diabetic shoes with soft inserts, and making sure that they don't develop another ulcer. And this is where it's important that a patient is looking at their feet every single day, making sure that they're wearing socks in their shoes. You'd be surprised how many people don't wear socks in their shoes, and just taking really good care of their feet.
That's awesome. And, I think it's easy to, surmise or distill down where we prevent inside of the dental space. And that is when we see our patients for their routine periodontal maintenance. It's important to know, though, that when we deliver that periodontal maintenance, that periodontal maintenance should be based on the patient's need, not just based on some arbitrary number every 3 months, every 4 months, but rather what makes sense for the patient. And one piece that I really appreciate about this verbiage that perhaps we can start integrating in the dental space is that this procedure is actually the prevention of recurrence. How often do we use that in dentistry? We never do. And yet we really do struggle because oftentimes our patients don't see value in that perio maintenance appointment or why they need to come in, because they're always getting good news. Everything looks great. Yep. Gum tissues look awesome. Yes. Since we've done that periodontal treatment, everything looks great. So the patients now think, so I don't need to come in every 3 months. So now it's important for us to help drive home pieces like the prevention of recurrence. Okay. Thank you so much for joining me, Dr. Sanders, for this fast fact. This is like crazy. The 8 steps of chronic wound care. Thank you so much for helping us to dip our toe into the water, as it were, around chronic wound care. My hope is that this at least gave a bit of an insight for those of us plaque slayers, our oral healthcare practitioners out there, that you do in fact treat oral wounds in a similar fashion to what our podiatric surgeons are doing. And it's important that we really understand the value and the worth of what it is that we bring for our patients experiencing systemic disease. So thank you, Dr. Sanders, for joining me. This was
Thank
such a
you
delight.
for having me. This was so much fun. I love
so
talking
good.
about wounds and diabetes with you.
I know. Yeah, you guys don't want to sit at our Thanksgiving table. So with that, thank you for joining me, Katrina Sanders, for another episode of Fast Facts Perio Edition. Stay tuned next week as we continue the conversation around fast facts and periodontitis. Cheers.
Yeah, this is a tale, oh yeah, a tale of 2 hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of 2 hygienists.